Well, first of all, thank you very much for inviting me to speak at this wonderful conference, which has a very varied range of topics, and I hope that you're finding everything satisfactory so far. I'm going to talk about menopausal hormone therapy and the risk of dementia. I have no conflicts of interest. So first of all, what do we mean by menopause? There are various definitions, but essentially it's the age when menstruation ceases, although sometimes it's defined as 12 months after having the last period. The mean age in the UK is currently 51. About 80% of women experience significant symptoms, which include a variety of things like hot flushes, night sweats, mood changes, vaginal dryness, reduced libido, etc. Typically, symptoms may last 4 years or more, but in 10% of women, up to 12 years. So this is a significant proportion of people's lives. And there are some long-term health risks from the menopause, most notably loss of bone density and osteoporosis. There is nice guidance on the menopause and its management, first published in 2015, updated 4 years later. The pathway reproduced on the right, it dates from May last year, but it will in fact be withdrawn. And the guidance covers the headings shown on the right. In revising the guidance, NICE will be looking particularly at the long-term risks and benefits of menopausal hormone therapy, cognitive behavioural therapy for menopausal symptoms, and issues around urogenital atrophy. So menopausal hormone therapy is most often referred to as hormone replacement therapy, although if you think about it, that's not strictly true, or abbreviated to HRT, and sometimes it's known as hormone therapy. There are, broadly speaking, two forms, either combined estrogen and progesterone therapy, or estrogen only, which is generally speaking given post-hysterectomy. There are various presentations of MHT, including tablets, patches, implants, gels, and sprays. And the duration of treatment in practice is quite variable, typically around 5 years, which reflects the average duration of symptoms. But in some cases, women take MHT for 10 years or more. And there are side effects from hormone treatments. These include such things as fluid retention, bloating, breast tenderness, mood changes, vaginal bleeding, and possibly weight gain, although that's controversial. There are certainly some long-term risks, including elevated risk of venous thromboembolism, stroke, but not coronary heart disease, and breast cancer, although that risk has been demonstrated only to exist with combined estrogen progesterone therapy. And NICE guidance advises that the dementia risk is unknown. So what about estrogen and the brain? There's considerable literature on the antioxidant properties of estrogen, how it appears to have neuroprotective actions. Estrogen loss is associated with various cell level changes like mitochondrial dysfunction, neuroinflammation, synaptic decline, and potentially therefore cognitive impairment. And it's said to lead to an accelerated aging phenotype with brain hypometabolism. Sex hormones are also linked to DNA repair enzymes. And so the question arises, does estrogen deficiency contribute to the excess of dementia or Alzheimer's disease in women as opposed to in men? There's also literature on hormone replacement therapy and dementia. Initially, the findings from this were positive. In early studies were observational or small trials, and more recently has been a systematic review of epidemiological studies. However, these early research studies have got significant weaknesses. So, for example, there's a non-random allocation in observational studies with potential confounding due to other health issues. Basically, women who continue to take MHT may well be in better general health than women who are not, and this may therefore explain an apparent protective effect of the MHT in regard to dementia risk. And often what's measured is a proxy like imaging, or else, if there are trials, there are very small numbers. So in the light of this, the National Institutes in America set up the Women's Health Initiative, which began in 1991, massive, expensive study. Its main aim was prevention of heart disease, various forms of cancer, and osteoporosis in menopausal women, not initially memory, but I'll come on to this. It included a clinical trial, an observational study, and a community prevention study. Overall, 160,000 women between 50 and 80 were involved at a cost of over $600 million. The randomized control trial of hormone therapy versus placebo recruited 27,000 women. However, there were two treatment arms, one of combined treatment, which stopped 3 years early because of adverse health outcomes, and the estrogen-only arm continued somewhat longer, but also stopped early because of problems. And then within the Women's Health Initiative, there's WIMS, or Women's Health Initiative Memory Study, which is a sub-study and consisted of 2 RCTs of combined treatment or estrogen alone versus placebo. Again, quite large numbers, 7,500 in the combined trial and nearly 3,000 in the estrogen trial. And trial 1 showed actually an increased risk of dementia, much to everyone, somewhat to people's surprise, with a hazard ratio of about 2. However, despite the large numbers in the trial, actually the numbers of people developing new dementia during the follow-up period are really quite small. So the difference is based on 40 people in the treatment group as opposed to 21 controls developing dementia within the follow-up period. Trial 2 showed no effects of estrogen alone on MCI or dementia, and therefore menopausal hormone therapy is not recommended for preventive treatment of dementia. And indeed, the Women's Health Initiative overall had a major effect on the numbers of people taking menopausal hormone therapy. And I'll show a slide a bit later from our own data, which shows a large decrease in the numbers of women taking such treatments. Possibly the studies overreacted to perceive risks and didn't really take into account symptomatic benefits, but nonetheless, it's unlikely that another large-scale trial is ever going to be undertaken to examine possible dementia risk because of the likelihood of non-benefit and also just the cost and duration of doing it. And so therefore, to investigate further the question about potential dementia risk of hormone therapies needs other approaches. So this is our contribution published in the BMJ last year, and I'll describe this study. The study was funded by NIHR School of Primary Care, and the lead investigator was Anna Vinogradova, with other colleagues from Oxford, Nottingham, Southampton. So the aim of our study was to assess the risks of developing dementia associated with different types and durations of MHT by means of a large observational study which used data containing as many known risk factors as possible and was powered to consider complexities of drug variety, treatment regimes, exposures, patient characteristics, and so forth. And the protocol, if you want more detail, the reference for the protocol is included below. So the design of the study, we performed a nested case control study. We used 2 national general practice databases, Q Research and CPRD Gold. Women aged over 55 with no dementia at the start date. Cases were included from a period 98 to 2020. Cases of dementia were determined mainly from GP records, but we did use other sources, including prescriptions for cholinesterase inhibitors and death certificates. And where the type of dementia was recorded, which is far from 100%, we also included that, so we could look at subtypes of dementia. Each case was matched with 5 controls with the same year of birth. So to say a little bit more about Q Research and CPRD, they're 2 of the largest UK general databases. Q Research has about 1,500 participating practices, and the data are linked to hospital episode statistics and ONS mortality data. CPRD is somewhat smaller, and only half the practices are linked to the official data. One methodological quirk is that they use different computer systems and some different codings, so it was not possible simply to combine the data from the 2, but I'll explain how we got around that. So we measured MHT exposure from prescription records. We only counted prescription records that were begun 3 years before the index date of dementia diagnosis, because we wanted to avoid something known as protopathic bias, i.e. people might start or stop taking treatment during a period where dementia symptoms are actually emerging. The exposure to MHT was grouped according to the preparation and presentation, and there were 5 categories of exposure duration, ranging from never to at least 10 years. And we subdivided the group into age of starting MHT as well, either side of 60. We also included a lot of covariates because these are the things that bedevil risk factor research. So we looked at lifestyle factors, self-assigned ethnicity, family history of dementia, records of early menopause, gynecological history, menopausal symptoms, comorbidities, and the use of other relevant drugs. Statistical analysis is a very statistical paper, so I'm treading on thin ice, but the main analysis was run separately on each database. So there were 2 main analyses. The risk of dementia associated with hormone therapy exposures were assessed using conditional logistic regression and presented with odds ratios with 95% confidence intervals. Then we used meta-analysis to combine the odds ratios from the 2 databases, and the main paper reported analysis from the pooled results, and that's what I'll show shortly. We calculated risk both as rates and as numbers of excess cases, and we performed a number of secondary analyses, including by type of dementia. So we had nearly 120,000 cases and nearly 500,000 controls. The mean age of cases was 83.5, with approximately 16 years of clinical and prescription data for both cases and controls. About 14% had exposure to MHT before the index date. Women taking MHT were in better general health and more likely to live in prosperous areas, although for some reason they had higher rates of anxiety and depression too. And this graph shows the change of prevalence of taking MHT from the early 2000s, which, as I mentioned earlier, is related to the findings of the Women's Health Initiative study in the States. The main analysis is summarized in this slide. The more important set of results on the left-hand side with the forest plot in the middle of shown in the middle of the slide, which is dementia, the risk of dementia of all causes, either associated with combined treatment or estrogen only. And if you look at the forest plot, you will see that none of the odds ratios are significantly different from one. In other words, there's no increased or decreased risk of dementia associated with MHT. The analysis on the right is based on a smaller group of cases with diagnosis of Alzheimer's disease, and you will see that not for estrogen only, but for the combined treatment, there is a slightly significant increase in the risk of cases of dementia with longer exposures of at least 5 years, and this increases to an odds ratio of nearly 1.2 for 10 years or more taking MHT. So it's important to notice the figure shows the adjusted analysis. We've included all types of MHT, and the most important finding is that there's no significant increased risk for dementia as a whole. Considering our additional analyses, altogether 34% of cases had a recorded diagnosis of Alzheimer's disease, and as I mentioned from the forest plot, for longer exposures, 5 years plus, women receiving combined treatment had a significantly higher risk of developing dementia compared to controls. There were no significant differences between different hormone preparations, be it drug or presentation, and cases with an earlier onset age, less than 80, or longer use of estrogen only, had a delayed onset of dementia compared with those who had onset dementia over the age of 80, a finding that is maybe a little hard to interpret. One way of looking at the Alzheimer's disease analysis is to consider the numbers of women who developed dementia. So the left-hand column, you can see that in the total sample, the rate of the number of cases of people not exposed would have been about 39, and women receiving more than 10 years of MHT would have led to about 7 cases altogether, 7 excess cases altogether. So it's an estimate of the kind of size of effect that you might see. So in conclusion, we found there was no overall increase in dementia risk from MHT. This was irrespective of types of hormone dose, application, and when MHT was initiated. The subgroup analysis of cases with Alzheimer's disease did indicate an increased risk of up to 20% with more than 10 years exposure to combined MHT, but this is not necessarily a causal association, and there may be other reasons why people who had a diagnostic label of Alzheimer's disease differed from those who did not. Our study has several strengths, particularly the size of the large representative general practice population. So we've included much larger numbers of cases and controls than in reported trials, including the WIMS study. We're able, therefore, to adjust for potential confounding variables. We're able to compare different hormone preparations and durations of exposure. Also, we've had consistent results from 2 independent databases, which increases our confidence in our main findings. We may, for issues of recording, have underestimated MHT exposure in the early years of study, although it's not clear how that might have affected the findings. And our findings regarding a possible increased risk with Alzheimer's disease and longer exposures may not be entirely robust. Our study provides useful data to address questions about MHT and dementia risk, and in general I suggest that the findings are probably reassuring for women. It's important that we should note the possibility of an increased Alzheimer's disease risk with longer periods of exposure, and this suggests that extended prescribing of MHT should be done with caution, but this is already important since we know that other risks like breast cancer also start to increase with longer duration of MHT. And prescribing decisions need to consider the potential benefit of symptoms, of treating symptoms, not just the risks of treatment. And this reflects the situation in most of medicine where it's important, where there's always a balance between symptomatic relief and any treatment risk, be they short-term or long-term. And I thank you for your attention, and I'm happy to answer any questions. And if one of them is, what's that? It's a Blakiston's fish owl from Siberia.